Now I'm pleased to introduce Jenn Batterton, Manager of Special Initiatives with the Allegheny County Department of Human Services. She will present on DHS's current work with the community to transform the county's crisis response systems. Following Jenn's presentation, we will hear from Gabby Warner, Harm Reduction Services Coordinator with Prevention Point Pittsburgh. Gabby will present on research and principles related to harm reduction and the services that Prevention Point has been offering Allegheny County for over 26 years. Welcome, Jenn. Thank you for being here.
Good afternoon. Thanks so much to all of the Diversion Summit presenters and to Connect for organizing this opportunity. My name is Jenn Batterton, and I work for the Allegheny County Department of Human Services, where I support efforts to prevent the arrest and correctional control of people who, with help from human services and healthcare, could live healthier lives in the community. The summit organizers asked me to speak about this work, and specifically about the county's work to improve our crisis prevention and response system. To ensure that first and foremost, people are aware of and have access to culturally competent trauma-informed care in the community, and that law enforcement need not be the first or only response to someone experiencing a behavioral health crisis. In the language of the sequential intercept model that Dr. Mulvey discussed earlier, I am talking about the continuum of services at intercept 0, even before someone encounters a police officer. The system that, if working optimally, means that people with challenges are getting the kind of help, the kind of preventive help they need, so that police need not be tasked with helping them. But our work to improve the crisis system also recognizes the reality that that police have been burdened by the work of supporting people with needs. So we must look there too. What can happen differently when emergency services are engaged? When someone calls 911, a police officer arrives in just a few minutes, even if not with all the right tools to help someone in crisis. We can change that though. Like so many around the country, we can imagine a crisis system that sends a mental health professional or team as quickly as we have come to rely on police response. We are not there yet, but that's the direction we are heading. And LEAD is too. When police encounter someone, they should have alternatives. They should get to choose to honor someone's humanity. And we've heard from so many officers and chiefs and others that they want to help folks get to care, but they need our help to do that. DHS is supporting the development of pre-arrest pilots because it is one very promising way for us to build a system that no longer views jail as a primary, if deeply flawed, method for connecting people to behavioral health care. To advance this work, DHS and 911 convened a crisis response stakeholder group that met regularly for about 6 months until earlier this year. It included representatives from law enforcement, from community organizations, from local government, from academia and healthcare, who brought their lived and professional experiences to the table to identify the gaps and propose needed solutions for our crisis system. This group mapped our current system and also examined its racial disparities, which are stark. They drafted recommendations and engaged additional stakeholders to weigh in and further refine those recommendations. Through a series of listening sessions, we heard from frontline service providers, law enforcement officers, and individuals who themselves or with family members have experienced, and too often negatively so, different aspects of our crisis system. They told us what they needed: more places to go when mental health or substance use symptoms are escalating, more places that are open after hours, who won't refuse you regardless of your state, a streamlined way to understand what services are available, better follow-up care, more discharge planning, more community and peer-operated supports, and more mobile responders. Ultimately, in February, the group published a set of 16 recommendations as part of a public engagement survey that DHS circulated broadly. We received nearly 400 responses to this survey and got a real sense of how the community would prioritize each recommendation. For example, the leading recommendations following public feedback were related to improving the quality and increasing the availability of 24/7 crisis walk-in services, improving mobile crisis options and functioning, and improving discharge planning from both jails and hospitals. The group also recommended establishing more community-led crisis prevention models, as well as dispatching civilian responders directly from 911. You can find a lot more information about the recommendations and the process that this group went through on the Allegheny County DHS website. So how is the county implementing these recommendations? What's happening now and what's to come? So our work right now is focused on some of the following things. We are working hard to strengthen the partnerships that we heard clearly need to be strengthened. For example, between our service providers and law enforcement. We're also working to improve existing services based on the recommendations and public feedback. We're working to enhance mobile crisis capacity and to improve response times and to incorporate even more peer support into our crisis continuum. To do this, we're focused on applying for funding and also on creating solicitation opportunities to support these enhancements as well as new pilots in partnership with community. And we're also assessing data gaps so that we can understand what information we need to collect differently or better to be able to know if new efforts are working. So I think that's my 10-minute mark. I'll sign off now, but I will be available to answer a few questions following the panel discussion, and look forward to hearing from all of you as we continue this work to improve the county's crisis system. I hope that you will feel free to reach out to DHS to provide continued feedback, and know that we are working to establish better feedback mechanisms, and also just that we are always grateful for that feedback, even when it is critical. So thank you very much, and enjoy the rest of the panels.
Hello, everyone. My name is Gabby Warner. I'm the Harm Reduction Services Coordinator for PPP. Thanks for sticking around to the end of the day to listen to me talk and to think with me about what it means to have less arrests for people who use drugs. I'm going to talk about Prevention Point Pittsburgh's work, and spend a good bit of time talking about harm reduction and the practice of harm reduction. And I'll also spend a little bit of time thinking about how LEAD could potentially serve the community of people who use drugs, who too often, end up being targeted by police and then pushed further into precarity as a result of the lack of resources, support, and respect that that institution provides. I'll leave my email at the end of this presentation because I know that I will be going through things quickly. So feel free to reach out if you need any clarity or you just want to have a conversation about something that I talked about today. So Prevention Point Pittsburgh is a syringe service provider here in Allegheny County that operates through the lens of harm reduction. So before we talk about Prevention Point's work, I just want to come into some common language, common understanding about what harm reduction is. So these are ways that we might see harm reduction in our everyday lives or more regularly, right? So maybe not a Knight's helmet, but like a bike helmet. So you've got cigarette filters, a seat belt, condoms, a life jacket. So all of these devices came out of this understanding that certain behaviors, certain activities came with the possibility of certain harm, um, certain types of harm, right? Or the possibility of harm. So these devices were created to minimize and reduce the harms associated with those activities. And it's broadly defined as a set of practical strategies and ideas aimed at reducing negative and destructive consequences that are associated with drug use. It is a social justice movement that is founded on the belief and respect for people who use drugs. And first and foremost, harm reduction seeks to approach this global dilemma by treating those who use drugs and those with substance use disorder with compassion and care. And if you want to learn more about harm reduction, if this piques your interest, please visit the National Harm Reduction Coalition. A lot of the information that I'm sharing with you today is work that they have done. So often harm reduction is talked about meeting people where they're at. So simply what that means to meet someone where they're at is that we don't expect folks to reach a set standard, set expectations, a threshold, to be able to receive respect and engage in the exchange of care. We know that when we're meeting people where they're at, we are actually able to co-create a space in which we can put our assumptions, our predetermined outcomes to the side to understand the needs of that individual, given their own circumstances, their own knowledge, and their own experience. And this is vital because, we know that some folks who use drugs have other complex issues and needs going on, right? And this is not an exhaustive list, but these are some of the things that can be happening for folks. And I also just want to say that just because someone uses drugs doesn't mean that they will experience all of these things or even one of these things, right? But we do see a correlation there. And so it's really important to think about the individual needs because of the many intersections that they have to navigate in their life, right? And because we recognize that there are complex issues and needs, we also understand that traditional drug treatment is not always a viable option, right? So this one size fits all actually doesn't work given what we know about people's individual experience, right? And their individual needs. And this is for a number of reasons, right? There's limited availability. You've got to catch 3 buses to be able to make it to the methadone clinic, right? And if you don't make it so many times, then you get kicked out of the program. So there's these barriers there, right? Also, we know that abstinence-based programs only work for a very small percent of people who use drugs. And there are certain risks that come with that. If there's relapse, there is an increased chance for overdose. So it's super important that folks have Narcan. And the research also shows that substance use disorder is a chronic condition. So relapse is a part of that process. And sometimes people just may not be ready to quit. They may choose not to quit. But we know that if we have an open conversation, a relationship of trust, that if they do want to make some changes for themselves, they're going to feel okay talking to us about it. Or hopefully we have built those pathways for them to feel okay talking to us about it so we can help them get to where they want to go. So these are some of the goals of harm reduction. Again, check out the National Harm Reduction Coalition for some more in-depth info on that. And these are the 6 principles of harm reduction, which very much overlap with those goals, right? So a focus on health and dignity. So establishing the quality of the individual and the community life and well-being as criteria for successful interventions and policies, right? So going to communities, going to individuals, figuring out what their needs are, what well-being looks like for them, and then using that as a way to create programs, policies, lead programs. Also participant-centered services. So non-judgmental and non-coercive spaces with a low threshold for services, as few barriers as possible. Participant involvement, so ensuring that participants and communities impacted have a real voice in the creation of programs and policies that are designed to serve them. And this is definitely important when we're talking about LEAD and the ways that it has been created to have community advisory boards, and making sure that the people on those community advisory boards represent the folks that LEAD is looking to serve in some way, right? It's going to be a vital piece to make sure that the program works. So participant autonomy, just affirming participants themselves as the primary agents of change. And then also recognizing sociocultural complexity. So we recognize the various social inequalities in which people are affected, both in their vulnerability to and capacity for effectively dealing with potential harms, right? And so when we're thinking about this, we can think about the ways in which there are higher arrest rates and incarceration for Black folks, Indigenous folks, Latinx folks. And this is not reflective of increased drug use, right? This is reflective of law enforcement's focus on urban areas, lower income communities, and communities of color. So that is, when we're talking about sociocultural complexity, it's recognizing all of that when we are trying to practice harm reduction. And then also just pragmatism and realism, right? So we do not attempt to ignore the real and tragic harms that are associated and sometimes associated with drug use. And more importantly, the criminalization of drug use, right? As well as illicit drug use and other risk behaviors. We don't want to minimize those harms that can exist, but do not always exist. But we also accept drug use as part of our world. We know it's not going anywhere. So how can we serve folks who use drugs, knowing that drugs are not going anywhere? So, why aren't we looking at why drugs are a problem? So if eliminating drug use is not feasible or even desirable, are there ways that we can address problems without necessarily eliminating drug use, right? And I think that is something that we have to think about. So we also just want to talk about what harm reduction isn't. It's not an anything goes approach. It doesn't enable drug use or high risk behaviors. It doesn't condone, endorse, or encourage drug use, and it doesn't exclude or dismiss abstinence-based treatment models as viable options. In fact, we want all the options in harm reduction because we recognize the vastly different ways in which individuals have to navigate the world and experience the world, right? So we want to have all options available for people to meet their needs. Okay, so thinking about Prevention Point Pittsburgh, I've just got a couple more minutes here. But what we do is we're the only syringe service provider in Western Pennsylvania. We operate in Allegheny County. We provide sterile injection equipment, smoking supplies. We do testing. We have a medical van that comes out to prescribe Suboxone for folks who need it and are looking to get that type of treatment. We do wound care, case management services. We provide condoms. We distribute Narcan. We do Narcan response training. And all of this is done as low barrier as we can possibly do it. So the services are free. The program is anonymous. We're never going to ask people for their name, and it's absolutely confidential. And Prevention Point, we actually just passed 26 years. We were initiated in 1995 through the work of volunteers, and were provided formal authorization and regulation of syringe access in 2002. And today we provide these services at 5 sites throughout the county. We've had, in 2020, we had almost 9,000 interactions with community members at these 5 sites. And we saw 592 new individuals coming to our sites, right? And that's another part where that trust piece is so important, because when people trust us, when people come to us and trust us, they will spread the word into their communities. This is a place where you can go get support, right? That is how these new people come to us, is through word of mouth and through that relationship that we have built. And so, thinking about LEAD and Prevention Point, and the communities of people who use drugs in Allegheny County, we recognize that the decriminalization of drugs is the best way to serve drug users, by dismantling systems which keep drug users distanced from the community and stigmatized. So decriminalization would open up avenues for care and support, right? New avenues that haven't been explored yet. And simultaneously, we also recognize that in the immediate, less arrests and less charges of people who use drugs will absolutely impact their lives and the communities that they are a part of, in positive ways. So replacing punitive measures and responses with supports and needs that are recognized by the individual is going to increase individual and community capacity. And I think a lot of these tenets of harm reduction that we talked about today are pretty vital in how successful the programs, the LEAD program can be for folks. And so with that, I know it was very, very short. I really wanted to read you this quote, but I'm happy to send it to you another time. I'm just going to read the last line of it, because I think that that's a really important takeaway. And just thinking about being a provider, right? Service provider. At best, we are resources with materials users will use to enhance the safety of their choices. At best, right? So again, thinking about participants and community members, as being the center, right, of the changes that are made, right? This is not something that we are applying upon people. So this is my email. I know this was so fast. This is the phone number and our website. Please feel free to reach out to me if you have any additional questions, or just want to have a conversation about what we talked today. I'm happy to share any resources that I can.
Great. Thank you, Gabby and Jen, for that wonderful presentation. So we're going to have a question for each of you. I am Bethany Hemingway. I'm the Senior Program Officer at the Staunton Farm Foundation. Jen, I'm going to ask you the first question. How can we go about funding or creating more behavioral health inpatient treatment centers or respite peer centers for the long term?
So great question. Hi, Bethany, and hi, Gabby. It's good to be here. So funding is obviously a huge question for all of this work. The good news is we are in a moment in our national sort of funding ecosystem where some good decisions are being made around funneling dollars to behavioral health and especially crisis response work. So DHS is looking to, for all the ways that we can draw down that money, and also how we can be creative about making that sustainable, because that won't last forever, but thinking about how we can be more creative about the way that services get billed to Medicaid, and how sort of other stakeholders who may not be traditional payers in the system could be drawn in. So it's another element that's certainly a work in progress, and we haven't figured out the sustainability plan for all of these endeavors, but it's certainly top of mind, and And I think, again, the upside is that the national conversation, including the sort of elected officials and folks who make decisions about big dollars, are centering this work right now, including incorporating peers more, and maybe less so. I mean, I think the conversation is more around sort of community-based as opposed to inpatient. But again, I think we're just sort of got to keep looking and drawing down and being creative with, and then being especially creative with how we can make this work sustainable.
Thank you, Jen. Gabby, now this question is for you. How do we provide services for healthcare related to previously incarcerated individuals, provide harm reduction for substance use, and get engagement of social services, including education, and employment? Not to put you on the spot, that's a big question.
Yeah, I don't know if I can solve all those problems or answer all of that, but I think, again, it comes back to this all really needs to be very person-based, right? We all have our ideas of how things would work best, ideally or systematically, but at the end of the day, we need to be talking to the individual who is having those experiences, right? And we need to see what tools are in our tool belt to serve them. And that doesn't mean that those services are already there, but what do we do with that information when we find out that there are gaps, right? I think that is going to be the most important piece. And then, you know, when we're talking about employment for folks, when we're talking about treatment for folks, again, thinking about the barriers that come with accessing those supports. That goes right back into an outsider supplanting their own ideas of what treatment looks like, of what care looks like, of what being a good worker looks like. And so, yeah, not a straightforward answer, but that's the best one that I've got.
I think that's a good answer, Gabby. That was a very hard question. Sorry to put you on the spot.
No
and thank you
problem.
for your wonderful framing of harm reduction. I have one last question, and Jen, I'm putting you back on the spot. Does the county or city plan to use the American Rescue Plan money to invest in mental health in the crisis system and in or diversion?
Yeah, so some of the dollars that I was referring to in my last response are certainly coming through through the American Rescue Act and other mechanisms as well. But we're looking at all the ways to leverage these new dollars. So yes, we're paying close attention to that money.
Well, thank you both, Jen and Gabby, for your presentations. So thank you both.
Thank
Have
you.
a lovely Tuesday afternoon.